Okay, so next is gastro-esophageal reflux disease. It's V9. And before commencing on the clinical scenario, I would like to discuss basic science. So technical aspects, while measuring the P24 or pH ambulatory manometric studies, we put the pH electrode 5 centimeter above the lower esophageal sphincter, and this sphincter is decided by the manometry, and the acid reflux we label when the pH is less than 4, and the patient records symptom occurrence, timing of meals, and supine periods. And pre-requirement is stop PPIs 7 days before the test and H2 antagonist 3 days before. Now scenario: a 35-year-old male is referred to your clinical A 35-year-old male is referred to your clinic complaining of severe burning intestinal pain, typical of gastro-oesophageal reflux. He has been taking omeprazole 40 milligram per day for 6 months uh, with minimal relief. How will you manage him? I would take a detailed history and ask about him any food regurgitation, any stresses of the food, difficulty swallowing down, and that might help to decide the cytosine and esophageal dysmotility. It is important to exclude the dysmotility before any anti-reflux surgery, and I would arrange an OGD, esophageal manometry, and 24-hour ambulatory esophageal pH monitoring to obtain the objective evidence of reflux before considering surgical management. My decision to offer reflux surgery will take into account both clinical and investigative findings. The most important determinant of a good outcome after reflux surgery is the appropriate patient selection. There are two groups of patients. Number one, who have no response or partial response to the medical treatment. Number two, those people who don't want to take the medicine lifelong. What parameters form the basis of 24-hour pH studies? What are the normal values? There are 6 components which we read on the pH 24 pH monitoring. Number one is total reflux duration. It should be less than 5% of the time. Upright reflux duration, supine reflux time, number of reflux episodes, number of episodes greater than 5 minutes in duration, and longest reflux episode. The most useful parameters are total reflux time and symptoms correlation. What is the D-Meester scoring system? D-Meester scoring system lowers acidity and correlates it with the symptom duration. It uses the 6 parameters tested on the 24-hour ambulatory pH study involving the patient position, number, and length of reflux. A normal score is less than 14.72. So normal score is 14.72. Anything above that D-Meester score, they have a reflux. Briefly describe the principles of anti-reflux surgery and the operation that could be considered. The main component of anti-reflux surgery are repair of the hiatus, and secondly, perform a fundoplication. The fundoplication can be Nissan 360-degree wrap, or it could be partial anterior and partial posterior. Sometimes different approach may be necessary when there is a large paraesophageal hernia. This tends to occur in elderly, and it's necessary to only repair the diaphragmatic defect and perform a gastropexy without a fundoplication. What would you discuss when consenting a patient for anti-reflux procedure? The outcome is successful in 90% of the patient. There is low mortality, about 0.3%, and surgery is the only treatment that actually stop the reflux. And there are risks of postoperative dysphagia temporarily for 2 to 3 weeks, early satiety, unable to belch, unable to you might feel a gas, bloating, and increased flatulence, and the risk of recurrence of symptoms. What is the controversy surrounding the total versus partial fundoplication? No evidence supports one technique over the other. Many surgeons perform a partial anterior or partial posterior fundoplication because the risk of postoperative dysphagia and wind problems are less. Concern about the exacerbating and existing dyspneic disorder. Evidence suggests there are a few wind-related problems following posterior partial posterior compared with the total fundoplication. There may be more dysphagia with total fundoplication. Similarly, evidence suggests there are less dysphagia with the anterior following an anterior fundoplication, but at the expense of higher recurrence rates. Now, another controversial question is: does the division of the short gastric vessel to create floppy valve during a nasal fundoplication reduce the incidence of postoperative dysphagia? So some surgeons believe that failure to divide the short gastric vessels leads to increased incidence of early dysphagia. So once they divide it, they have a floppy valve mechanism which patient don't have dysphagia. And other published data, however, do not show any difference in dysphagia with or without short gastric division, but there is some evidence to suggest a higher incidence of wind-related problem following division of the short gastric vessels. Thank you.